All right, good afternoon, everybody. Welcome to the first of our UX speaker series in HCDE. So it's my pleasure to be your host for each of our speakers this quarter. So we're going to have a wide range of selection of speakers from industry and nonprofits speaking on the topics of human-centered design and practice. And so our first speaker of the series to kick us off is Brian Clark. And Brian is a service designer at Seattle Children's Hospital, where he's worked since May 2020. So I assume remote when you got started at the time. He applies human-centered design methods with clinical, research, and service teams to improve patient and family experience, care quality, and ensure equitable access to care. Before Seattle Children's, he was at a variety of service design, experience design and service design leadership roles, including Kaiser Permanente, West Monroe Partners, and Sierra Trading Posts. So Brian can also stick around a little bit after the talk as well, too, if you have questions. So he's going to talk for about 30 minutes and have about 20 minutes of Q&A. So think about the questions that you want to ask. There'll be lots of time for questions and answer afterward. And with that, let's welcome Brian.
Thanks. Super excited. I'm always happy to talk about service design and the work we do at the hospital. So yeah, I'll probably have a hard time getting me to shut up. But I guess just give you a brief overview of what I want to talk about. Wanted to, I guess, give a quick intro to the hospital for those of you who aren't familiar with it. Talk for a few minutes about my career path, because I didn't go to engineering or design school. And then really talk about how we apply these in the hospital and in the teams I work on. And I'll walk through a case study of a long-term project we've been working on for almost since I started 5 years ago. Sort of a long-running, multi-iterative project we've been doing to give an example of how that work shows up, how these things get applied, and sort of the problems we're trying to solve with service design in the context of the hospital. So. If the technology will cooperate. Okay, so Seattle Children's Hospital, for those of you who aren't familiar, is about a mile that way, maybe a mile and a half, so it's pretty close. And we're the academic, sort of the med school partner for the UW in terms of the pediatric side. Hospital's been here since 1907, so almost 120 years. And the core mission, vision of the hospital, add a few words here and there for the marketing boilerplate, but this is sort of the core of what the hospital's always been about. Making sure that kids can get access to care regardless of if their parents' family can pay for it. So making sure kids in the community have access to high quality care. And those words, hope, care, cure, in particular care, are going to come up a lot today. There's 400 beds in the hospital. It's the largest geographic region for any children's hospital in the US. So we are sort of the center for families in Alaska, Montana, the northern part of Idaho, and obviously Washington. So families are coming from, some of them from Bellevue, and some of them are flying from, far northern Alaska, which you could get to Paris and back faster than they can get here. So 60 different specialties. We also have a whole range of regional clinics and partners all around the area that they work with in terms of different hospital systems. And I think the other piece in terms of the community we serve, all of you probably are aware of this living here in Seattle, but some of the most diverse communities, most diverse zip codes in the entire country are right here. And just as an example of this, last year, over interpreters for over 80 different languages were used at the hospital. It's probably closer to 100. Some of them a lot, Spanish, for example, and some of them maybe once or twice in a year for some, native languages that are indigenous to, say, Central America, things like that. So really, really broad range of folks that we need to serve. I guess talk a little bit about my background, given that I didn't go to design school, didn't go to engineering school, yet pretty much nothing having to do with human-centered design. I guess maybe to start, my connection to UW. So this is my grandfather with his fraternity brothers back in the 30s. So my grandfather went here, did for his BA and his law degree back in the 30s. My dad was born here, lived in Seattle for a long time. I've lived in Washington about half my life, but the rest of it was spent all around, sort of corner to corner, different places in the US. But graduated high school in Mount Vernon, so kind of local, I guess. And that sort of informs my connection here. And both of my brothers got care at the hospital growing up. My family, my wife's a professor at the University of Puget Sound, down in Tacoma, psychology professor there. I've got 2 teenagers who obviously weren't real stoked about being dragged up and down the mountains in Italy or up to the top of cathedrals this summer. And then an older daughter who's out at Brown University in Rhode Island. So that's just the little blurb about me. So my path to the role that I have now, I just want to talk for a few minutes about it because a lot of questions come up about it. I like to think that my path to having a design role, as a career, actually started when I was at University of Iowa, where I did the first half of my undergrad degree. And Jay Holstein he's a religious studies professor, a rabbi there, and he was like the first class I took that was really about what are the questions people ask about meaning going back to Gilgamesh? And I won't bore you with that long lecture or anything, but there's sort of like core, like why do people do the things they do? What is the meaning that people try to find? And try to understand and explore that. The second half of my undergrad degree was at Indiana University, where I finished my BA in religious studies, Middle Eastern studies, and history. And I spent most of my time there studying minority religious communities in the United States and trying to understand the development of identity and relationships between those things. My senior year, I got a research grant to go do fieldwork studying the relations between the Nation of Islam and the African American Muslim community and more recent immigrant Muslim communities from the Middle East. This mosque in Cedar Rapids was founded by people from Lebanon and Syria back in the early 1900s. So those communities have coexisted, but very different identities. So that was really where I started social science, understanding how to apply tools from anthropology, sociology, doing ethnographic fieldwork, interviews, observational research, which is sort of at the core of the work that we do at the hospital. Didn't do a very good job of doing those things, so like a lot of lessons learned in that. But that was sort of the starting point for how to do that work, how to understand and listen to how people do those things. For graduate school, after that, I went to Harvard Divinity School with the intention of trying to study with Diana Eck, who's part of the Pluralism Project. I'm studying American religious pluralism, how different communities develop their identity, and how people navigate that and applying those meanings into civil society. So, how they do community organizing, how they do, sort of maintaining your identity in these various minority religious communities coming to America, and how do you balance those things? And got to work with a lot of, learn from a lot of really interesting people. It's a weird place if you've been there, but some really interesting people. You got to, listen to lecturers and professors who have done things in the world and bringing back that applied knowledge, which I found really, really rewarding. After that, long story short, ended up back in Colorado, working at REI. They paid for my MBA, so go REI. And I did my MBA at Colorado State. And the connection there really is about how do you work for impact in your work, in a sense, in terms of applying those things in business? How do you learn how to have an impact, how to organize, how to lead people in terms of a business, but actually drive towards results? So those sort of component pieces together are sort of the starting blocks for me. But after my MBA, the reality of working outside of outdoor retail, when I started working in consulting, for those of you who haven't seen this movie, I highly recommend it. For those of you who know what movie this is right away, you'll know it. But the reality of working in corporate America and working in a consulting company, there's a lot of upsides to that. Learned a lot of things, but there was a lot of compromises you make. And I think the baseline of wanting to work places that have a purpose that you can believe in and working together towards a common purpose, that baseline was set working at REI and in the community organizing that I was involved in when I was at Harvard. So luckily, after about 4 years for a couple different consulting companies, the last client I had, who ended up being my boss and now is my boss's boss's boss, I guess, at Seattle Children's, worked at group health. So about 9 years ago, actually 9 years ago next week, started working at group health and then at Kaiser Permanente, doing experience design and doing essentially in some way or form the work that I do now at Seattle Children's. So doing service design, experience design work across sort of the ecosystem, some of it small scale tactical, looking at 2 screens on the mobile app and the information that's there, up to, how do people join the organization as a member and navigate the first year of getting care when they've never been part of the organization before. So whole range of different parts of that system. The real upside of this, after a year, group health became part of Kaiser Permanente, and Kaiser Permanente has a long history going back over 20 years of having a very formal, structured human-centered design program across the 9-10 states that they're in. They started working with IDEO, I think, in 2003. So this is something that's much more structured, formalized, and has a lot of resources behind it. Applying it in both the clinical space and improving patient care, the service space, customer service, in technology, and how the technology works together. The first real web portal for health records was developed in-house at Kaiser, and my boss there, Tim, was one of the first people that set that up in the 90s to actually have electronic medical records for health. So they had a long path there, and that was a really great opportunity, working everything from doing one-on-one interviews, like ethnographic research with elderly home care patients, going to people's houses and interviewing them to understand their needs, up to these sort of big events where we're teaching people how to use design thinking, how to use human-centered design as a way to do their jobs better, not to become designers, but to apply those tools when they're doing whatever their job is, being a nurse or being, customer service person on the phone. So that, right at the beginning of the pandemic, I decided to change jobs and start working at a hospital. So for the first 2 years, I only knew people at the top half of their face, either that or you're online. But got to work with some really neat people over the last few years and doing a lot of the same kind of things that you've probably done on projects, in terms of that, if you think about the double diamond of human-centered design and design thinking, it's the same kind of, pass of those things, but doing it in different contexts. So our team, and this is a question that Julie asked, so our team the name's changed a couple times, but right now it's the Experience Research and Design team, and we are in the space of the family's experience at the hospital. There's another team doing human-centered design, and they're the innovation team, and they're focused on clinical innovation in terms of the delivery of care and the direct care. So they might be building things for kids with elbows that are bad and experimenting with those kind of things. Or, how do they get the tubes to work when you have a baby so that baby can't pull the tubes out or whatever. Or hand washing safety, things like that. And then there's another team doing human-centered design and elements of that are directly involved with either patient-facing, family-facing technology, or provider-facing, for the various technology ways that implements in the hospital. So shows up a lot of different ways. But those are sort of the 3 buckets at the hospital and at Kaiser and at Group Health that really human-centered design shows up in the healthcare space. It's either technology, the patient care aspects of it, or sort of the service aspects of it, because I'm not really dealing with the patient care part, but everything that wraps around it, the whole big system. So how does this sort of look at the hospital? I think starting with the very idea of what a hospital is and what that means, it really is about enabling care and caring. The very word hospital comes from Latin, meaning somebody who's a foreigner or a guest, and the word for hospitality and sort of welcoming a guest. That's where that a hospital in the Middle Ages was more of a B&B. You visit a village, somewhere to stay when you're traveling. So this idea of hospitality, caring for your guests, is sort of at the root of what that word means, and I think that gets at both sort of the model of the hospital, but also what the work is about. It's about enabling care to happen efficiently and effectively, making sure that those outcomes happen for the children, but also that the caring, the human side of this, in terms of there's people actually making that work and making it work so it's a decent place to work for people, but also a decent place to be, oftentimes for parents' worst day of their lives. Oftentimes, you find out your kid has a hole in their heart. I mean, it's just, for those of you who aren't parents, it's just like the heaviness of some of that is, it's hard for people. It's not Disneyland. Service design is definitely not this. So a lot of times, I think we spend a lot of time just explaining it to stakeholders and to people we work with. I think of all the places I've working in the hospital, you have the most people with advanced degrees. I mean, it's ridiculous. You're in a room like this size and everybody's got MD, PhD, advanced degrees. They're all very, very smart about something other than design. And so they know how to, do brain surgery on an infant. They know to do heart surgery on a baby who's not even born yet. But how to think through a design process, or how to do ideation, or how to actually think through those things, that's not something that you go to school for when you go to med school, right? So, you're up against this high evidence barrier, but you have to make it explainable. It can't be a black box. And so we spend, I think this is, and all these are stolen from different places, this idea of combining these things, trying to use evidence-based methods, trying to use things from social science. My boss is an anthropologist, so really sort of applied anthropology is one way to look at it, and other sort of evidence-based approaches to make sure that we can quantify things, that we can document things. We're not doing IRB-approved research. We're not doing clinical research. So it's a different bucket, but we still need to provide evidence if we're going to make suggestions that change the path of care for people. But also gluing that together with things that go back to IDEO and design thinking and all the kind of methods that are sort of those standard mindsets. You're trying to glue those things together. I think for us, a big part of this is you're taking that model that exists, but really thinking through some sort of key elements. In healthcare, the stakes are higher, but the rules about everything are higher, the evidence, and the expectations. So we're really thinking much more upfront about the outcomes and the process in terms of equity and equitability of those things, both enabling it and in both how you do the work, but the outcomes that are generated. Is it effective? Is it safe? Is it actually improving quality, the quality of care for the children? Are we doing it in a way that's inclusive and safe, that involves people? I think the next to last one here around trauma-informed care, I think the pandemic has put this almost at the top of the list, because that really put that in everybody's sort of front of the list, because it became very obvious that this is, you all lived through it, right? So you work in a hospital, not only is it hard for the parents and the kids, everybody works in the hospital system, not me. I don't have to be, in the ER for 14 hours straight. I get to just walk outside and whatever, but it was really, really hard on people. People were stressed out, had nurses hit with chairs, everybody's stress level's way too high. So I think having a sense of the trauma-informed approaches to design, at least in the healthcare space, but I think really anywhere, it's worth spending time on. I'm not going to go down that rabbit hole, but it's very important to understand that if you want to actually meet people where they're at and not cause more harm. I use this visual a lot, talking about service design, to kind of differentiate from some of the other UX design, UI, things like that. And this simplifies it in a way, because you're talking about the delivery of the service, the supporting services of the service. But the minute you start to unpack this, you realize this doesn't even really capture it, because you have to think about, well, how did they get to the theater? It's not just if they have a seat and can they get their popcorn before the show starts. It's, well, what language do they talk coming in the door? Can they read the program you handed them? Are they able to sit in the seat you gave them? What were their previous experience with the theater? If they're going to be traumatized by the production, do we have enough water for the stage crew so they don't faint in the middle of the production? All the systems and backing all the way out in a system. So, service design can play out in very small scale. We do projects where it's literally one survey implement. Do these questions work? up to, the full sort of lifespan of somebody's, relationship with the hospital. And I think this has been a hard lesson, and this is stolen from Lou Down, is this idea that service design is really about 10% design. That's like the fun part, going to interview users and like watch what people are doing and the actual like design stuff. The other 90% is getting people to actually participate, getting the conditions right, setting up the systems, sort of creating the conditions to make that happen and allow it to happen, which when I started was very frustrating. Like, I already explained this 4 times. You've got a PhD. You should be able to understand this. So not necessarily with our families, but with, people that make decisions. Like, as a designer, you have to learn how to navigate some of those frustrations without having people kick you out of the room. Lesson learned. But that's a lot of the time that our team spends. I mean, we might have 6 months of just getting it set up so we can do a 1-month-long study, because we have to make sure we cross all the T's. It's safe. Nobody's going to be harmed by it. It's not going to impact patient care. Nobody's going to, everybody's included. Do we have all the right interpreters so that people can participate? It's this whole ecosystem just to be able to do some study that only takes 6 weeks, 4 weeks. And so what that looks like for our team, and everybody's seen this by now if you're here at this school, right? So, it's that same double diamond if you're going to simplify it down, but our team does both sides of this. I'm more on this side, doing participatory design, service design, and that's really the space I'm in, is helping co-design solutions with people. But a whole bunch of our time is spent on the design research side, and we have large projects that only do that side of it, because the team, the clinic doesn't know what their family's experiences are. They want to understand what they can do better. So we spend a huge amount of time just trying to inform clinicians. Well, this is what people actually want. This is what they say they need. This is where things aren't working well, so they can make some decisions, and then we can go to the other part. And the project I want to spend the rest of the time talking about here is work we've done around Alaska Native communities and families that come down to Seattle for care. Because this is really a project I've been working on in some pieces really for like 4 years now. It's broken out into 3 pieces here. The first part was really the design research piece and trying to understand needs, and this has led to 2 other projects. One small scope service design project around care coordination, and one much larger scope looking at the entire service across the entire hospital system and all our partners. And this has led to this whole downstream of a whole bunch of other projects. So this sort of iterative process of this work. Families from Alaska come from all over the state. So we have people coming from all sorts of different communities. Many of the communities in rural Alaska have less people in them than 1 floor of the hospital. They have less people than who's in this room. And so some people that live in those communities, they've got a PhD in petroleum engineering. They work for an oil company. They've been to Seattle. They've been around the world. Some of those people have never left the village. So just like here, you've got that whole spread of diversity of experiences. You have a new parent. It's their first kid, and they find out they're sick, and they have to come to Seattle. So we're trying to help families, regardless of where they're from, navigate that experience. And how many of you have been to Alaska? That's probably a good maybe question to stop and ask. A few people, right? It's a really big place, and I don't think I ever wrapped my head around it until having to think through it and going up there. And it's a very, very different. Part of it is kind of like here, and part of it is a long, long, long ways away. So, we have families coming from Southeast Alaska, from the Gulf area, from sort of the far north and along the Bering Sea and the Southwest Alaska, and very different communities, very different needs, but also very, very mixed in terms of the health systems that are supporting them. So we have a family that lives on Little Diomede Island, which is in the middle of the Bering Strait. I think it's a village of like 60, 70 people. It's a fishing village. And there's a grandma who has a kid that she's the guardian of, who has a heart condition, but the grandma's in a wheelchair. most of the time. So when the kid needs to come down here, they need an adult to help the grandma, and then they have to take a helicopter to shore, and then a flight, and then another flight, and then they can get to Anchorage, and then they can come down here. Going on vacation, okay, but traveling with a sick kid and thinking about doing that, it literally takes them 2.5 days to get down here just to do like an echocardiogram to check to make sure the kid's heart's okay. So there's a huge thing. I mean, the distance we're talking about here is really the same as if flight miles, we're not talking time. You can go to Tampa, right? And this is like asking people, for those of you who might be from Europe or have flown over there, it's like saying, okay, I live in Helsinki, I need to take my kid to an appointment, you gotta go to Porto, Portugal. It's a long ways away. It's not going over to Yakima. So, and the health system, the Alaska Native tribal health system is very well organized and has a lot of resources, but it covers this huge area. So we're trying to work with these partners spread across the system to understand they have different resources. Some areas have more money to help the families, some have less. And so a lot of this service is dependent on those interrelations with those services. So just, to give a sense. So the project we've been working on started in 2019 with the cardiology department looking at health outcomes as well as family experience surveys. If you've ever gone to the doctor or anywhere where you get those satisfaction surveys, they have their use. But so like looking at the disparities in that, who's having a bad experience, who's having bad health outcomes, because that's the most important part. People are unhappy, that's important, but it's the kids' health, that's why we're all there. So they started digging into that, and this was really meant to be a connection between their quality improvement project and quality improvement process they already have in place from a clinical side, and trying to expand and understand, well, what's the larger sort of social system around there that's related to that? Because it's not just about the child's health condition that drives a lot of these outcomes. It's where they live, where they fly back to, the resources the parents have, the resources and the access they have to the pharmacy or other services once they go home. So we started this really, and this is going to be the same iteration a couple times here, doing ethnographic research, observations, site visits, sitting, watching how the work gets done, observing with families, doing a lot of interviews, both with, I guess, broadly families, so the adults that take care of children, which aren't always parents, and talking to kids, and spending a lot of time actually also talking to people that take care of them, both the ones that work for Seattle Children's as well as for all of these different health systems, to understand, like, well, what are the issues that are happening, and then what are the root causes of some of those things. We did a lot of different versions of sort of co-design work, which I'm sure all of you have done in projects, doing their Post-it notes. I think I burn less trees now that we've gone virtual a little bit on these things, but it's the same. You're doing ideation workshops, some of them in person, some of them online. I think I tried to blur out the patient families. Over and over and over again to try and understand how the system works, who's involved, how the care gets delivered, where the pain points are. And like a lot of these projects, you have these sort of traditional design outputs. So you're making storyboards to help tell a story so that you can communicate what you learned. So the people that write the check to make the decision to make changes understand those things from an emotional level. Journey maps, this is sort of just ups and downs. Each one of these had a separate 3-page thing that broke it out and all of the data that went with it. But a lot of it was spent on this sort of trying to unpack the experience, connect the dots for people, and also synthesize the feedback into what should they do and how should they think about delivering the experience. A big piece of this was about, really, healthcare is about trust in a lot of ways. And so how are you building or breaking trust in that? So, how can we want to be reliable and safe, but we want to make sure staff are able to come across authentically and respectfully. We can anticipate needs. We shouldn't ask for things that we know they already need. How many of you have gone to a doctor's appointment and you've filled out a form and you're like, they already have all this information about me. I listened to somebody I know in the back corner complain about this in a couple visits to doctors. I've complained about it, right? So a lot of healthcare is this sort of repetitive motion thing that causes a lot of friction, but it also creates a lot of mistakes because information doesn't get shared. So a lot of the focus here is thinking about the door-to-door experience for families, not just when they're in the clinic, not just when they're talking to the nurse or when they're in there for the surgery, but like thinking further back and thinking about when they come and when they leave, like trying to make it cyclical, while they're here, while they're going home, because it's the whole piece that interacts with that. So the recommendations out of the design research were really starting about that on-ramp. So this idea of like, how do we get people here? If we can get the right information at the start and make that part work, all that information can move downstream in the system and better decisions, better help can happen. All the root cause stuff we found for, say, discharge, there was all sorts of mistakes made in discharge or delays in discharge. So if somebody's discharge gets delayed, well, that costs a lot of money if they're in the ICU or in the hospital. Every day extra in the hospital costs a lot of money to deliver that care, costs a lot of frustration to families. Most of the problems there were because somebody at intake didn't share what they knew about, like, well, this person's from a town that doesn't have clean running water. So if they have a situation where they need to have that to go home, then you can't send them back to their village right away. They can go to Anchorage and stay at the hospital there or something. Not rocket science, but if the information doesn't get shared and we don't collect those things, we can't be proactive about it. So a lot of it was about trying to identify those things and then working with the care coordination and the nurses to really build out. So this is probably the most service blueprints, right? That's a core thing for service, process flow. So there's about 40 different teams and people involved in like one family moving through that. But like looking at actually what information needs to be shared, who needs to share it, how do you improve visibility of that information and help people move through that system. So, and doing that with the care coordination team when they had something that was completely ad hoc. Every case, they just sort of started over, wrote notes, shared the notes, which, if everybody's on the ball, it worked great, but there was a lot of inconsistencies. So two of the tangible things we were trying to drive to, one obviously was trying to have families say they had a better experience, but to really try to think about like, what are the impacts and try to drive that down. We had a lot of times where we had last minute cancellations of surgeries or, these sort of people not showing up for appointments that were our fault. It wasn't the family's fault. It was, we didn't share the right information. We didn't do something or help something happen. So trying to really eliminate our mistakes was a big part of this. And so that, of course, made the leaders happy because that's less money being spent. Or it's, if you don't have to cancel the surgery, that kid gets their surgery sooner, or you can get another kid in there so you're not delaying somebody else's care. The next stage of this that we've been working on over the last year is thinking and going sort of large across the whole organization, not just with one clinical unit, but a lot of the problems were really about the whole system, not just in one area. So we spent a lot of time thinking about that same on-ramp, but thinking about the systems that provide care across the whole ecosystem. And a lot of different people involved, a lot of different sort of ways of doing that work. Sort of cognizant of time here, so I want to jump ahead a couple slides here. Part of this was trying to unpack the system that supports people, because the heart center, the cardiology team, was the first group we worked with. But there's a lot of other people involved. Some of them help people from Alaska a lot, and some of them have one family a year, so they don't know the context. So a lot of it was trying to understand, how do these systems work together? What does it mean when they go home, but when they're going home to far northern Alaska versus they're going to Anchorage? It means very different things. We've had families that have had to literally move to Washington because of their kid's diagnosis, because there is nobody to take care of their child in Canada because they have, a specific liver condition or kidney thing. There isn't a pediatric nephrologist that's willing to take on the care of their child anywhere in Alaska, so the family's having to uproot and move here. So the context really matters a lot in trying to understand these things. So we spent a lot of time with that same iteration, talking to people, going and doing site visits, collecting outcome data, but also that observational data about how people interact, where they run into those problems, and what those issues are. So we're at the next stage of this. This is actually spiraling off into, it's way more than 6 projects, but we're about to pilot a whole bunch of small changes that are outcomes of this. Some of them are just like literally changing a flyer, so that the flyer that's handed to families has the right information based on where they live and the health system they're in, instead of some generic thing. Like, oh, you live in Bethel. That means you go to this hospital. That means you need to call Joan. But no, wait, you live in Fairbanks. So that's, Chief Andrew Isaac Medical Center. So you need to have a different, it's just personalization, just basic, you would think basic kind of stuff. But, the little things like that can have a big impact. But we're also looking at, we've got people advocating for changes with the state of Alaska, or our foundation trying to raise funding to improve, availability of money to actually have housing here in town. So some of these are big things. Some are in the middle, dealing with Epic, who manages sort of the entire health ecosystem of technology for medical records. But a lot of this is about the number of people and voices that have to be involved. Over the course of the last 3 years, these projects, we've had interviews, in-depth interviews, not just sort of intercepts, but long, hour and a half conversations with over 75 different families. Oftentimes both parents separately or together, and their kids. Over 200 different employees in the hospital in terms of different clinics and roles and nurses and, security staff, the guy who drives the shuttle back and forth to the airport. Every sort of, you can run the gamut, there's heart surgeons, things like that. The different, clinics and teams that are involved, and a lot of people externally as well, all these different organizations and community partners. It doesn't work without them, because we're not their primary care doctor. We're not who's going to help take care of the child once they go home. So really trying to make sure those things work, and making sure that the families have sort of an equitable connection to those things. I'm almost done, so we can have a discussion. So I want to real quickly just say none of this would have happened. So I know they're not here, but the people in the Heart Center were vital to making this happen, and a lot of partnership and sort of making the conditions to make the work happen. People in Alaska are awesome. So if you ever moved to Alaska and you need to get your kid taken care of, the doctors up there are awesome. But also, just the sheer number of people that are involved in delivering care for you think it's one family and one kid, and there's 50 people involved before they even get here. So the sheer sort of mechanics of how delivering care happens is really complicated. So this is the last thing I want to say. So this is something that when I had an office, Land Before Time, before COVID, I always had this sort of on my wall. And I think this is sort of the core when I think about being a service designer, doing work that you can feel good about. For me, is about this idea of that contrast with indifference and actually caring. And because it's not about not knowing, it's about indifference. And that's sort of, if you think about a lot of the critiques made of human-centered design, of design thinking, it's usually a function of the business's indifference to the outcomes in some way or another. It might be carelessness, but a budget being made to spend money or to spend time on listening to the users, or if you're not even healthcare, right? But those decisions that are made are a reflection of sort of the ethics behind the work you do, and the indifference. So that outcome that's here, I think, and taking the time to care is the crux for me that connects together sort of my path to becoming a designer as well as the work. So I guess I should stop, and then we can talk about anything you want to talk about. And I'm not in a rush, so yeah.